Okay, welcome everyone. It is 7 o'clock in California, and we are very excited to have you all join with us again for the Foundations in Critical Care webinar series. Very excited to introduce all of our panelists from across the globe. With us this morning, we have Dr. Rachel Kimani, who's an anesthesiologist at Bagathi County Hospital in Kenya. We also have Eugene Yushimi, who is Rwandese, but working in Canada currently, and so is affiliated with the University of Rwanda. Eugene is a colleague of mine for many years now. He is an anesthesiologist, also has expertise in obstetrics anesthesia as well as simulation. Danielle Devakis, very excited to have Danielle with us today. Danielle is a nurse, but is also a nurse practitioner who has done a nursing fellowship in critical care medicine and works with us at Stanford University. Dr. Rebecca Walker is one of our core faculty for the Foundation series. She is trained in emergency medicine and also works at Stanford University and is very experienced in running a lot of the global health programming at Stanford. Mr. Eddie Owino is a good friend to me now as a nurse from Kenya and works in the intensive care units at Stanford University as well. Very excited to have Mr. Owino with us. He brings lots of experience, the nursing perspective, and is in a unique position in that he works both in a high resource setting as well as a resource constrained setting. So very excited to have his perspective with us today. Dr. Sammy Benjamil is a surgeon as well as a critical care physician. He trained at Stanford University, but recently graduated from his fellowship training and now is outside of the Chicago area in Illinois in the United States. So very excited to also have Sammy here with us and the surgery perspective. Today we're doing frequently asked questions. If you've been with us on other webinars, you know that the first 4 sessions were on shock. And so we have lots of questions talking about shock. And then our 5th webinar session was on mechanical ventilation for ARDS, asthma, and COPD. So we'll get into a little more of those discussions today. Just a few points about housekeeping and etiquette. We want to keep this as a respectful learning environment. So if you see something that you disagree with, please bring it up with respect. Everybody has a different education. Everybody has a different practice setting. So we want to be respectful of all of our diversity and differences. You are encouraged to turn on your video if you have the bandwidth. This session is being recorded, so your presence here today is your consent to being recorded. If we reach maximum capacity, this is also being streamed live on YouTube, so you can follow along there. And all of the resources that we present, whether it's a job aid or a cognitive aid, a table, all of those can be found on the Learning Resource Center, which I'll show you in just a second here. Closed captioning is available. You should be able to see that at the bottom of your Zoom screen. Closed captioning might be helpful for those who are non-native English speakers. The LRC, or the Learning Resource Center, is our online school. Again, all of these sessions, the video recordings, the slides, the resources, everything is available free online on the LRC. You can use the camera function on your phone to scan this QR code, which will take you directly to the website for the Learning Resource Center. Additionally, participants who do stay for the full session will automatically receive a certificate of attendance. You will also receive an email notification. If you follow this email and fill out the evaluation, you can receive continuing medical education credit. This is the same as CPD. You can receive that CME through Stanford by following the links in the email and filling out the evaluation. We are very grateful to the Department of Anesthesiology, Perioperative, and Pain Medicine at Stanford for sponsoring this CME for all of you for for free. Um, So we've had 5 webinars thus far. Again, the first 4 sessions covered shock, including distributive or septic shock, hypovolemic or hemorrhagic shock, cardiogenic shock, and obstructive shock. The 5th webinar session discussed mechanical ventilation strategies for ARDS, asthma, and COPD. Today, we will recap some of the most commonly asked questions and answer a few of the questions we did not get to during the previous webinar sessions. So with that, I am going to allow, to the first section we will talk about are the 4 main categories of shock: distributive, hypovolemic, cardiogenic, and obstructive. And with that, I'm going to turn it over to my colleague, Dr. Andrea Komisky.
Good morning, everyone from California, and thank you again for joining us today. We always appreciate such a robust audience. So as Dr. Crawford has already stated, we're going to go over frequently asked questions. And the first question today that a few participants asked in previous seminars was, how can someone differentiate between distributive shock and other kinds of shock outside of the ICU in particular? And so a big reminder for this question is that shock is a life-threatening condition, and it causes circulatory failure, inadequate oxygen delivery to meet cellular metabolic needs and oxygen consumption requirements, producing cellular and tissue hypoxia altogether. And the effects of shock are initially reversible. However, they can become rapidly irreversible, resulting in multi-organ failure and death, which is why this is so important to recognize early. Next slide. Thank you. All forms of shock, as we know, have low blood pressure. And so the most important first step is identifying that the patient is in shock, as previously stated. This includes the assessment by physical exam, to determine if the patient is well perfused, and some signs that the patient does have low blood pressure and decreased end organ perfusion would be that they have altered mental status, they're cold and clammy on their extremities. You notice that they have decreased urine output with oliguria, or they're completely not producing urine at all. And you may even find delayed capillary refill. And then on top of that, the critical second step is to treat them quickly within the window that they can begin that you begin your initial assessment, because this is the window of potentially irreversibility. And so some of these interventions include IV fluids, antibiotics, getting source control if you can identify a source early, and then identifying the cause of the underlying shock, which could be anything from infection to their heart not effectively working. So,
oh, go ahead.
No, go ahead.
I was going to say, I think I wanted to introduce Dr. Rachel Kamani as well, who's part of our panel today.
Yeah. So going back, thank you, Rachel. Hi, Rachel. Thank you for joining us. So going back to distributive shock, which was the question, it also known as vasodilatory shock. And this is associated with decrease in your systemic vascular resistance. So the resistance of the blood vessels. If you think about circulation as a pumps and a pipes problem, then distributive shock would be described more as a pipes problem. SVR cannot be measured directly, and it does require a cardiac output monitor to achieve the correct calculation. But septic shock and other forms of distributive shock can also be just based solely off of your clinical exam and your clinical findings. The decrease in SVR leads to a compensatory increase in your cardiac output and may even be seen with a faster heart rate in these patients. And so having a high clinical index of suspicion upon with like the various etiologies listed here as sepsis, anaphylaxis, you can have toxins, certain medications, neurogenic, so spinal cord injury, they will all demonstrate low blood pressure in the early phase, and they will also notice warm skin, brisk capillary refill, and then this may eventually lead to cold and clammy if the shock progresses enough to where they are trying to compensate even more. The pulse pressure will be wide, and you notice that the neck veins can either be distended or flat depending on the patient. And then imaging with ultrasound will most likely reveal a hyperdynamic heart, so something that's beating very fast and collapsing. And the IVC may also be collapsible with respirations. If you do have an A line, it's nice to note that there could be some variability with your lung exam. So that's something to take note of. And you may also be able to find evidence of infection with your ultrasounds, or even notice signs of cirrhosis, such as like ascites within the belly on your ultrasound as well. And then this has been seen in our previous seminars, but I think it's really nice to come back to remind that this is the one-pager reference that we always have used in the last 4. It can help determine the various features of shock based on the different types of shock. And so distributed also, as previously stated, usually a result of sepsis is the most common, but always helpful to remember that anaphylaxis, adrenal insufficiency, also neurogenic, and medications can cause this. So take the time to scan the QR code on the screen, and you can access this at any point in time as a great resource.
Great. Thank you so much. I do want to say that some people are asking for the slides. All of these slides will be uploaded to the Learning Resource Center. So we will give you that QR code again, and that link we can put in the chat. And then as we go along for individual resources, you can see that there's a QR code that you can scan with your phone, and that will take you to the website directly. But the slides will definitely be made available to you all.
Excellent. And this slide as well with the resource on POCUS. So just a quick, easy assessment utilizing your ultrasound. This is available through the QR code as well on the top of the page, but as Dr. Crawford has already alluded to, we will hand out the slides, or there'll be a way to get to the slides later. This is very, very helpful in assessing patients in shock, because you can assess the contractility of the heart in particular, look at their volume status by looking at their IVC, as well as the contractility of the heart. And then you can also utilize it to look at other areas of the body. Ultrasound is becoming more and more available in most resource settings. And so we definitely highly encourage you to download this to review the pocket guide. So that way you can start to incorporate ultrasound more readily in your daily practice. It can be extremely helpful in identifying all sorts of pathology.
Yeah, I love this resource so much. You can literally open it while you're scanning the patient. It tells you what position you should place the patient in, which probe to use, and how to obtain each of the views for the heart, for the IVC, for the lungs, also for scanning patients' lower extremities to rule out DVT. So I think this is just such a great resource to use. And I actually use it in my own practice too, just to remind myself to get all of the views and help quickly determine what could be going on with the patient. I think this slide is for Dr. Kamani.
Yes, hello everyone. I'm Rachel from Kenya. So as we continue with these frequently asked questions, there are some things that we came across, and there are questions on which is the best clinical score to use for shock. There are various scores, and there's the QSOFA, there's the Apache, there's the News, and there's the News 2. Previously, there was the Muse, which has now changed to be the News, and all these scores are used in different scenarios, and they're not specific, or I can't say that there's one specific one that you'll want to use. But just to give a breakdown, like the Apache, what it does, you want to look at the severity of the illness, and it has the various physiological variables. So you're looking at respiratory rate, you look at the blood pressure, you look at the pulse rate. So all these variables will help to predict the mortality or the progress of the morbidity of the patient. So it's one of those scores that is mostly used in research. It helps to give an inclination of where patients belong when you're dealing with critical care illness. We have the SOFA, which this one looks at the level of severity of the illness, and you're looking at are the organs dysfunctional, and it looks at 6 various organs. One of them will be the kidneys. It predicts more of mortality predictions. And then you have the Q-SOFA, whereby you have 3 variables, which is the GCS, the respiratory rate, and the blood pressure. This one will help you determine when to escalate. And then now from the Muse, in the UK, mostly they're using the News. And the News helps you to determine the degree of the illness. So you're trying to understand how critical is a patient, and helps you have some sort of early detection of clinical progression. So you're looking at the pulse rate, you're looking at the heart rate, you're looking at the saturations, and also the GCS. So for instance, if a patient has a GCS of less than 4, you know that patient is severe. If their heart rate is also less than 40, you know that patient really needs escalation of care. So it will predict at what point do you need to get to a higher level of care. So having an idea of all these scores helps you understand the mortality and the morbidity progress of the patient that you have in your critical care units.
Yeah, thank you, Dr. Kimani. I think even I have sometimes become confused because there are always developing more and more scoring systems, but I think it's really important for us to realize some of them are just to describe the patient severity and are used in research, so to compare patients across groups in research. But some of the scores help us determine how sick the patient is clinically. I think it's really important also for us to recognize that during the last sepsis guidelines, surviving sepsis guidelines, the Q-SOFA score was being used really commonly and still is being used in a lot of places to identify patients that are sick with sepsis or septic shock. But the last guidelines actually recommended using something else other than Q-SOFA because it was not deemed sensitive enough. So if you use the Q-SOFA score, you may actually miss some of the patients that are really sick. So I think if we had to pick a score, I personally would pick the News 2 score. This is the updated news from the News 1 or the first news scoring system in the UK. So, any other thoughts on that, Dr. Kimani?
No, and nothing to add. Just what I can actually try and say is the News 2 is good. So you could follow the QR that gives a full description of what it entails, but it mostly looks at now the dynamics and the parameters that you want to look at when you're managing the patient. I think it's now picking up. Back at home, we're still using the Muse, but we're trying to introduce the News to practice.
Yeah. So the people are still asking in the chat which score to use, and I would recommend the News 2 score. I think another thing that's a bit challenging when you're in the clinical setting is doing these calculations and remembering which parameters are part of the equation or the overall score. This QR code here is really helpful because it goes to an online calculator, and this calculator can be accessed both online, but it also can be downloaded as an app on your phone. So it's called MD Calc. And so I find that really useful because then I don't have to remember which parameters I'm looking at to determine the score of a patient. So unfortunately, Dr. Eugene has to go back to the operating theater. He's working clinically today, so if he can come back, he will. But I wanted to just quickly introduce another scoring system. Dr. Kimani, were you planning on talking about this slide, or would you like me to go through it?
No, you can go ahead.
Okay. Yeah. So I want to introduce people to another tool that can be used at the bedside. It's called the VSDT, or Vital Signs Directed Therapy. Again, you can use that QR code to download this chart to make it easier to read, but this can also be used at the bedside, and in a large cohort of patients was found to actually improve mortality in patients that were hypotensive or having a low blood pressure. Essentially, the vital signs directed therapy protocol tells you which vital signs are normal and they are color coded as green, which are abnormal, color coded as yellow, and which are danger signs. So those are the red ones. And unlike the other scoring systems, it actually tells you what to do about it. So if you have low blood pressure, it recommends you give some fluid. If you have hypoxemia based on your pulse oximeter, it tells you to start oxygen. Additionally, it will tell you when you should recheck the vital signs. So how long after the intervention should you wait to recheck the vital signs? And then at what point do you escalate this patient's care? I think this tool is very, very helpful, especially for nurses that are on the wards or maybe even in the intensive care unit who may not readily recognize which signs are danger signs and who, I think a lot of times we just call for help, but our seniors may or may not be available. And so there becomes a delay in patients who might be at serious risk or in danger. So it gives us the tools to take that first step intervention. This tool was developed by a group called the EECC Network, or Essential Emergency and Critical Care. It's now called EECC Global. And they do really, really great work at helping us to identify and rapidly care for patients who are critically ill, even outside of the intensive care unit. So I think this tool is incredibly, incredibly valuable for that. So how can you clinically diagnose and differentiate anaphylactic shock intraoperatively? I think this is a really good question. A lot of our previous webinars have concentrated on shock states, but not necessarily specifically in the operating theater. So I think this is a really great question. So I'll go ahead and walk us through this. As an anesthesiologist, I am always ready to identify and treat anaphylaxis in the OR. But the first thing to note is that you have to have a high index of suspicion. So when somebody has anaphylaxis in the operating room, it's usually related to something that we have done in the operating theater. So some of the most common things that we do is we give patients medications. We also clean the patient's skin and prep them for the surgery. We also have lots of devices that can be antigens that the patients are exposed to. One of the more common ones is latex. So there's oftentimes latex in some of our medical equipment. We used to use almost all latex gloves. We've definitely moved away from that practice. Even chlorhexidine, which is a surgical scrub and cleaning solution, can be an antigen that can lead to anaphylaxis. What we need to do is not only have that high index of suspicion, but we also need to recognize it quickly. There are lots of things in the operating theater that can cause hypotension and tachycardia, but we need to recognize that those two signs, vital signs, so low blood pressure and fast heart rate, can also be signs of anaphylaxis. But in addition to those signs, you can have bronchospasm or wheezing. So you can hear that with your stethoscope. If the patient is intubated, if the patient is not intubated, you may hear that sound just with your ear. Patients may flush or get a rash or hives across their skin. If they're awake, they may say they're dizzy. They may get confused. They may have some nausea that's often related to that hypotension. And if the patient's awake, they may complain of itching as well. So really, it's the hypotension and tachycardia, which is the shock state of anaphylaxis, but it's often associated also with bronchospasm and flushing or a rash. Again, it's really important to understand the most common agents that lead to anaphylaxis in the operating theater. Neuromuscular blocking agents or paralytic agents such as rocuronium, vecuronium, succinylcholine. Those are some of the more common medications. The other medications that are really common in anaphylaxis are the beta-lactam antibiotics. I mentioned latex gloves and latex medical equipment, chlorhexidine. Also, colloids can be associated with anaphylaxis, as can dyes. We often use a lot of injectable dyes and different types of surgeries, and those can also be related to anaphylaxis. So again, a temporal exposure to these agents that leads to hypotension, tachycardia, bronchospasm or wheezing, flushing or rash. Those are all signs and symptoms of anaphylaxis in the operating theater. We highly, highly recommend you download this resource as well. It's a pocket guide. It's available online for free. It's available in multiple languages, including French, Spanish, Chinese, Dutch, Korean, and Portuguese. Very, very useful. Additionally, it's now been released as an app. Unfortunately, it's only for iOS or Apple devices, but you can use this online just as readily. So essentially, it has lots of emergency events that happen within the operating theater. So it's really, really great for those of you who are working in theater. So anaphylaxis is definitely one of the scenarios listed in this cognitive aid or emergency manual. You can see that anaphylaxis is an acute process that happens quickly after the patient is exposed to an allergen, such as the medications, latex, chlorhexidine, as we mentioned. This cognitive aid outlines the clinical features of anaphylaxis. You can see that at the top of the first page. And again, these signs and symptoms that you can see clinically include the severe hypotension and tachycardia or shock. Also includes bronchospasm, wheezing, flushing, rash. Anaphylaxis is severe and very fast form of shock. It must be identified and treated immediately to prevent this patient having further morbidity and mortality. You can follow the steps in this protocol. They help you to inform the team, to manage the airway and oxygen. It helps you to ensure adequate IV access and begin the treatment. Treatment includes IV fluids and medications such as epinephrine or adrenaline. It's really important for everyone to understand that epinephrine or adrenaline not only supports this patient in shock, but is also a key treatment of anaphylaxis because it stops the anaphylaxis process. So it helps to stabilize mast cells, for example, so that they don't continue to propagate through the anaphylaxis process. So epinephrine or adrenaline not only supports the patient's shock, but also helps to stop the anaphylactic reaction. So very important. The agents, again, that are most commonly causing anaphylaxis in the theater is antibiotics, specifically beta-lactam antibiotics, muscle relaxants, dyes, latex, chlorhexidine, contrast, colloids. A couple other things to consider that can lead to this anaphylactic type reaction are blood products, protamine, and sugammadex. Those are some other agents that are often used in theater that could lead to anaphylaxis. Okay. Mr. Owino, can you help us talk about lactate and sepsis, please?
Yes. Hello, everyone from California. The question is, how high does lactate need to be for us to decide there's a septic shock? And typically, when we send the lactate, the general number is greater than 2. And so if it's greater than 2, that is normally a sign that we are dealing with septic shock. And sepsis, which is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. So patients with septic shock can be clinically identified by vasopressor requirement to maintain mean arterial blood pressure of 65 and above, or if the serum lactate level is greater than 2 or 18 in the absence of hypovolemia. So for adults with sepsis or septic shock, the suggestion here is guided resuscitation to decrease serum lactate in patients with elevated lactate level over not using serum lactate. So the first response is usually fluids, and then if we can't maintain that MAP greater than 65, and at that point, vasopressor, which mostly is Levophed, is normally ordered to help to achieve that mean arterial goal, which is the pressure we need to make sure that there's perfusion in the end organs.
Perfect. Thank you, Eddie. So I think some of the nuance here is if you were to ask the question again, how high does the lactate need to be? The simple answer is 2. But the nuanced answer is that lactate is not specific. It just simply indicates that you have an anaerobic process going on, which is, in this case of septic shock, most likely related to decreased perfusion. I think it's also important, as you pointed out, Eddie, that you have to fluid resuscitate the patient and start vasopressors when needed using noradrenaline or Levophed or norepinephrine, whatever you want to call it. It has several names, but in different parts of the world, it's known as noradrenaline. Some people don't have noradrenaline, so they may use adrenaline. But as long as the patient is fluid resuscitated, and pressors are started if needed, and the lactate continues to be elevated, then you have your diagnosis there. One important point that we talk a lot about in the intensive care unit is that lactate may or may not be cleared readily, even with fluid resuscitation. The patient population that I think of the most for this are those with severe liver dysfunction. So if your liver is not working, the lactate will not clear readily. So even though the most recent sepsis guidelines recommend that we follow the lactate, it may not clear readily in our liver patients. So we have to keep that in mind when we're following our lactate levels. Thank you so much, Eddie. Danielle, do you have any ideas about using steroids in septic shock? And actually, this was a question in the chat box already, so people are very interested in what you have to say here.
Yeah, so hello from California. I'm Danielle Devakis, a nurse practitioner at Stanford. So when to start steroids in septic shock, we'll jump right in. If we could go to the next slide. Great. So short answer would be consider it in everybody. Septic shock being in adult patients with refractory septic shock, we suggest the corticosteroids, which we usually do hydrocortisone, 50 milligrams Q6 hours or equivalent. In a recent meta-analysis, they mentioned 260 milligrams per day, so 200 to 300 milligrams per day, continuous IV infusion, or divided doses of that 50 milligrams Q6 for 5 to 7 days or until ICU discharge. Sorry, this just popped up here. But refractory shock is defined as a blood pressure systolically of less than 90 for more than 1 hour following both adequate fluid resuscitation and vasopressor. So you're assuming that you're trending lactates like Eddie was talking about, you've given enough fluids, you just can't maintain this blood pressure that you need to sustain an organ perfusion. So that is a time to consider steroids and to consider in anybody who is not meeting those thresholds. In our practice here in Stanford, it's kind of do it in anybody who could benefit from it, because it could help morbidity and mortality if that is something that you have. If not, definitely consider it in everybody, especially ones who are in refractory shock.
Yeah, thank you so much. I think a couple other points that come up in the intensive care unit on rounds, Danielle, I think we talk about this all the time when we're on rounds, but is how long do you continue the steroids? So some of the people in the chat box are saying, it's really important that the very first step in managing sepsis and septic shock is actually fluid resuscitation. So if you've given that fluid resuscitation, the patient's blood pressure is still low, then the next step is to start vasopressors.
Correct.
So if you've fluid resuscitated and started vasopressors and they're still in shock, or your vasopressor pressure requirement continues to go up, go ahead and start the steroids. And then once we start the steroids, how long do we keep them on? So if the patient gets better over the next couple days, you really can stop them in 5 to 7 days. We have stopped them sooner if the patient just drastically improves. However, if the patient continues to be in septic shock and critically ill, you may actually keep them on longer. And the evidence is still evolving in this area on how long do you keep the steroids on, when do you pull them back? And then when the other question that comes up really commonly is, when do you need to taper the steroids? And so I think in general, for most of us, if we have the steroids on for 5 days or less, we don't use a taper for the steroids. We could just stop them. However, once you start getting into that 5 to 7 day range and longer, then you would probably consider a steroid taper. What do the rest of you guys think about tapering the steroids, and how long would you keep them on? Any other thoughts?
My thoughts are exactly yours because we work in the same institution.
Yeah. Dr. Komisky, Benjamin, any thoughts?
Yeah, I tend to go by the same thought process as well. Like if they get drastically improve after a day or two, you're starting to peel off pressors. Hemodynamically, they look like they're able to support themselves, and I'll just stop them without a wean. But if I notice that they're on for a longer period of time, like over a week, a slow wean is usually kind of what I aim for. So it's all very dependent on the patient. And then if they get worse, I just add them back on and then do a slow wean after that if I abruptly stop them. So.
Dr. Kamani, do you have any other changes or suggestions in the management of steroids and septic shock in your institution?
No, we use the same type of management.
Okay.
Nothing different.
Okay, wonderful. Someone is asking in the chat box about blood sugar management. Steroids will cause hyperglycemia. You will need to manage the patient's blood sugar. So especially in patients with diabetes that is refractory, you will have to probably start insulin, or we often will use an insulin infusion if the blood pressure, or excuse me, the blood sugar continues to go up. The thinking is that the greater threat to the patient's life is the septic shock, and that's more likely to kill them in the near term than is diabetes or hyperglycemia. So we do have to manage blood sugar, certainly when we place people on the steroids. So that's a great question, and definitely something that needs to be managed. Okay, who wants to talk about antibiotics? Dr. Benjamin, maybe?
All right, so another common question was about antibiotics, when do you start them in the setting of sepsis or suspected sepsis, and which ones do we use? And particularly, how do we choose the antibiotic before receiving any kind of culture results? So in terms of when to start antibiotics, for adults with possible septic shock or a high likelihood, you should start it immediately, ideally within 1 hour. And then with possible sepsis without shock, you can take some time to try to determine, investigate what the etiology might be. But if there's any concern for infection, then certainly within 3 hours from the time the sepsis is recognized. With the key principle being that while we do want to have in the back of our heads to be prudent with antibiotics and not just start antibiotics for every patient that comes in that might be hypotensive, they are life-saving for patients in sepsis, and there is been shown that there is a very time-limited amount where they have their maximum effectiveness. So being able to start that within that window while still being prudent is oftentimes a very nuanced decision. But if you find yourself questioning it, they should still be given as soon as possible, starting with the broad spectrum until you have a little bit more information. Then you can narrow it or potentially even stop it if you discover a different etiology. So that leads us to our next question, broad spectrum. Which ones do you start? So in general, the easy answer is you'll start covering all gram positives and gram negatives, right? A typical regimen might be cefepime, Pip/Tazo, or carbapenem, adding some MRSA coverage and antifungal coverage. And then this is depending on the scenario. And then this is where you start getting into a little bit more nuanced decision making, considering their history. So if this is someone that's previously been to your institution that potentially has already been on antibiotics for other reasons, and you potentially have previous culture data, then you can tailor the antibiotics to the individual in particular. But oftentimes we don't have the time or luxury to tease all this out. So if you're in question, broad spectrum coverage with the antibiotics I've discussed before is kind of our go-to. The most common organisms in sepsis are going to be your E. coli, your Staph aureus, your Klebsiella pneumoniae, your Strep pneumoniae. So always keep that in the back of your mind. And again, to reiterate, this is when suspecting sepsis, not just for anyone that comes in with any kind of potential infection. This is a really wonderful resource. Again, the QR, I know it's a little bit of a busy slide, but the QR code, if you scan it, will have all these images. And these are wonderful just snapshots of different antibiotics, antifungals, and antivirals and what they cover. I constantly pull this up just to refresh myself as I'm rounding or seeing patients, just to make sure that I'm using the appropriate antibiotics and making sure I have the appropriate coverage. So these are awesome sorts, particularly the antibiotic one that's going to show general overlapping susceptibilities for different bacteria.
Yeah, thank you, Dr. Sammy. I think these slides can be busy because we're offering a lot of the resources. These slides are not to be read. Really, we are providing these QR codes, and we will upload these slides to the LRC so that everyone has access to these resources. I think another good point to remember is that as through the history of time and the practice of medicine, the information has increased logarithmically. So, in older generations, we were expected to memorize everything and know everything, but it's almost impossible to know everything in medicine and to keep up with the evolving literature. So there's zero shame, and we encourage everyone to use resources that can help you. That's why they're called cognitive aids, to help you remember things. I will confess that infectious diseases and antibiotic management is not my strong suit as an anesthesiologist, and so I still have I'm not embarrassed at all to say that I often will look up coverage, especially when we start to get into some of the antibiotic resistant organisms. So I think it's really important for all of us to share these resources and which ones are easiest for us to use. And you don't have to know the answer right away, but you have to know how to find the answer right away. So I think I encourage you all to use these resources if you find them helpful.
Yeah, I'll just add to that. I mean, I completely agree. Things change so fast, and we have to recognize that it's impossible for us to know everything all the time, forever and always, with everything changing. So yeah, these kind of tools should absolutely be incorporated into your practice.
Great. Dr. Komisky, was this your discussion? Awesome.
Yeah.
Thanks.
So kind of
Thanks,
going
Dr. Benjamin.
Yeah. Dovetailing off of what Dr. Benjamin was saying, I think antimicrobials, starting broad and then trying to make sure that you're covering the necessary infections that your patients may have risk factors for is important. And so one of those potential bad bugs, as we would call them, would be MRSA. And so considering MRSA as a possibility for your patient based on significant risk factors, then we would start vancomycin in this scenario. Typically, we'll start with vancomycin and then peel it off if we feel like the risk factors are not there for MRSA, or if we have indicators stating that they do not have a MRSA infection. But it is good to keep that in the back of your mind as a possibility. MRSA overall, as many of us know, is a cause of sepsis, not only in hospitalized patients, but is now more readily seen in community dwelling individuals without recent hospitalization. So it's important to keep in the back of your mind. And so that's why we try to always start with vancomycin and then kind of de-escalate from there. It's important to recognize that vancomycin should be dosed renally appropriate, so based on what their kidney function looks like. And usually that's done by measuring vancomycin levels and then adjusting accordingly. And we have the lovely privilege of having our pharmacists help us out with the dosing. And so that's something that we try to do and keep their renal function in mind because it can be nephrotoxic.
Yeah, and just because this is a Foundations webinar series, I will say that MRSA or MRSA stands for methicillin resistant Staph aureus. So this is a Staphylococcus or Staph aureus that is resistant to methicillin. So it has resistance to lots of other antibiotics as well. So vancomycin or linezolid are the two IV agents most commonly used. If we want to go back to this slide that Dr. Benjamin covered, this will answer Alain's question in the chat box. You can actually use these charts to determine which other antibiotics will cover certain bacteria. So if you have an MRSA, but for example, you don't have vancomycin available, then this chart that you can pull up using the QR code, and again, these slides will be uploaded to the LRC, so you can check that later, will help you determine which other antibiotics might be effective, such as doxycycline or some other antibiotic that is available in your setting. So we realize not everything is available in all the settings, so we do want to give you these resources so you can figure out what is available in your setting and which microbials will it cover.
So another one that we always need to consider is Pseudomonas, which is another potentially and very dangerous bug for a lot of patients. And so questions to ask yourself as well with our MRSA infection is, does your patient have risk factors for Pseudomonas? Recent hospitalizations being one of the bigger ones, intensive care stay, are they bedridden? Do they have certain comorbidities that might expose them to Pseudomonas, specifically like your cystic fibrosis patients, something to keep into consideration. And so for adults who have sepsis or septic shock and have a history of having Pseudomonas, it's important to empirically cover them with certain antibiotics. And that table that was previously shown can help you identify which antibiotics to put on for these individuals. And so some of them are listed here, such as cefepime, meropenem, imipenem can be ones that we think of. Zosyn or piperacillin tazobactam is another one that we see very often. And just to remember, considering starting with this and then potentially de-escalating if you find that this is not the case or the source of your infection.
I think one thing to keep in mind, thank you, Dr. Komisky. I think one thing to keep in mind is in a higher resource setting, we are often able to get our resistance patterns of our cultures back relatively quickly. And so we can use those resistance patterns to determine which antibiotics to choose. In some settings, that's not always available. And so I think in that setting, and I would welcome Dr. Kamani and Eddie's feedback on this, but if you don't have culture data with antibiotic resistance patterns readily available, I think at that point you would look to the clinical course of your patient. So if your patient is very, very ill, you may want to double cover for Pseudomonas and be as conservative as possible to give your patient the best chance at survival. However, if the patient, for example, appears to be clinically improving and responding to treatment, then maybe you don't need the additional coverage. But what are the experiences of others, Dr. Kamani and Mr. Owino? What have you experienced in the more resource constrained, I would say, settings, even though I realize you work in high resource settings as well?
Hello, everyone again. In my experience, normally for the otherwise healthy population, the most likely infection, and just based on the symptoms, usually either malaria or typhoid, and therefore there's a delay in culture. Like for instance, the malaria diagnosis is pretty fast. With all the technology now, it's like a 3 to 5 minute thing. And in the settings where they do not have this capability, some of them will just pre-treat based on the symptom, like this could be malaria, and start those particular patient on anti-malarials or typhoid, like the Flagyl and all that. If they see an improvement, they continue the course. If they don't, then they might change some antibiotics as they wait for the send out. Yeah, some of the send out takes 7 even to 10 or 14 days to come back. So that is what I've seen mostly done, is a fluid resuscitation and then starting them on those antimalarials or anti-typhoids and all that.
Dr. Kimiani?
I've had an opportunity to work in a resource-constrained setting, yes, back at home, and also in the private facilities, which at least they will be able to do a blood culture and be able to figure out which organism the patient is growing. So in a situation whereby it's the resource constrained, we tend to have more of cephalosporins. So we'll now give our cefepime and cefatazidime. At times we also have cefazolin, which somehow it still works even in the really severely ill patients. So in that kind of setup, since we are not able to have that the profile of the microbial that is being cultured, we use that. Then on the other side, when you're in a highly resource-filled area, there we can be able to give our carbapenems. The most frequently used one is meropenem, and also we have the beta-lactams, the tazobactam. However, they're very expensive. So there's also the issue of cost for the patient. But always our first line is usually now a cephalosporin. Should it not work, now that's when we'll try the other carbapenems and beta-lactam, and it has worked in the past.
And what are you using for MRSA? Do you have vancomycin?
Yes, we have vancomycin as well, but yeah, it's also very expensive back at home, but it's available.
I think one of the other big considerations that's quite a challenge across the globe is the increase in antibiotic resistance. So when we do overtreat, so we're using antibiotics, perhaps like we're double covering for Pseudomonas, but the patient doesn't have Pseudomonas, then we actually are increasing antibiotic resistance. And so I think we really need to balance the risk and the benefit. So the risks being that we may not be covering the right bug, we may be introducing antibiotic resistance. But the other risk is that the patient may pass away or die from their septic shock. So I think we need to, with each case, weigh those risks and benefits. Additionally, I think as healthcare providers, we are all responsible for pushing our institutions to obtain the resources that we need to do this and do this well. I think antibiotic stewardship is one of the more globally pressing needs. If we start to have all of our antibiotics be useless against the resistant microorganisms, then we're all in trouble across the entire globe. So I think it's important to understand which ones to choose, yes, but also to make sure that we also get that access to the antibiograms of our institutions. So this is a much bigger, we could have an entire webinar just on antibiotics and antimicrobials, but definitely a lot to think about. Again, use those charts that we're going to provide, use those resources to help you make those decisions at the bedside. What about fungal infections?
Yeah, so staying in alignment with appropriate antimicrobial stewardship, I think in general, antifungals are not necessarily seen as something we start right off the bat. It's not a typical organism that we'll see in non-neutropenic or immunocompetent patients. And so invasive infections usually complicate a critical illness course, especially following certain risk factors such as certain surgeries, like upper GI tract surgeries. You can consider it with a risk factor of parenteral nutrition. If they've had a prolonged antimicrobial course and prolonged hospitalizations and seem to not be getting better, especially within the ICU, antifungals may be considered, and a fungal infection may be the cause of why the patient's not clinically improving. Other risk factors to consider as well are patients who have received chemotherapy, those who have had transplants before. So any patient who in general would be considered immunocompromised. These are infections to keep high on your radar, but not necessarily treat empirically right from the get-go. If you do have concerns about certain fungal infections like Candida or Aspergillus, a certain medication such as like voriconazole can be given. You can even do something like fluconazole. So all of your azole medications are something to consider, and then making sure that you keep an eye on certain end organ toxicities that might be caused from these antifungal medications. Caspofungin is another one that we'll use regularly if the risk factors are there, if we have a confirmed infection. And so it's important to keep these high on your radar, but not necessarily treat them right away, especially given resource constraints. They can be rather expensive. Even at our institutions, they are fairly expensive. And so we keep that in mind when thinking about these. If you look at the diagram listed above, it gives you a better idea of like where you might find some of these fungal infections coming from and where to think about the risk factors when considering treating these patients, just so that way you're not over treating or under treating. And one thing to really also note is that you can have Candida specifically in certain areas. That might not necessarily mean that you have a candidal infection, such as like in the urine. It's not uncommon that we'll see Candida growing in the urine or in the GU tract area. So to keep this in mind as not necessarily a compromising infection, just something that is a colonizer is what we would call it, something that naturally occurs and lives in the region. So any other thoughts?
Unless a patient is severely immunosuppressed, we do not treat Candida in the urine. So that is something I've definitely seen, but we typically do not treat Candida in the urine. It's considered a colonizer and not an infection. Yeah, great. I think another thought that came to my mind, Dr. Komisky, is, especially when you have complicated patients that are very, very ill, or let's say they have a extensive allergy profile. It can be even more difficult. Then we consider cost, availability, resistance profiles of microorganisms. It can get quite complicated to decide which antimicrobial to start and how long to keep it on, when to stop it, when to start it, et cetera, which patients. So if you can't have access to some of the resources and you don't find your answers in the resources that we have provided that will be on the slides that will be uploaded to the LRC, I encourage you to also use your colleagues. So use your infectious disease colleagues, ask them for help. I would say, especially if you have a complicated patient. Additionally, the pharmacists can be really, really helpful in these situations as well, with not only helping choose which antimicrobial, they can also help you with the duration, how long you keep your antimicrobials on. Additionally, they can help you with the dosing. So most of our patients in septic shock have some sort of liver dysfunction or kidney dysfunction. And so our doses may need to change. So I would encourage all of us to utilize our colleagues in pharmacy and infectious disease to help us with these very sick patients. What about transfusion, blood transfusion, Dr. Kimani? Would you use that as part of your fluid management strategy?
Well, there are two schools of thought. There are some people who think that using the blood transfusion would be a strategy to fluid management, but in the real sense, studies have shown that it's not a fundamental aspect when you're trying to manage the patient, because what happens, you need to first ensure that you've given enough fluid, and then once you've given enough fluid, depending on the HB of the patient, is when you can opt to now transfuse the patient. So a study has been done, and this study showed that patients who had HBs of less than 7 ended up having a less mortality compared to patients who were transfused who had HBs of above 9. So the conclusion in this study was that patients who tend to have a low HB of 7 the outcome is better compared to the patients who have HBs of 9 to 10. So the aim is to ensure at least if you're resuscitating a patient who has a low HB of about 7, you're targeting to get into a HB of 9. So this study had two groups. There was, I think, the restrictive and the liberal. So the restrictive is whereby now the patients had a low HB, and the liberal is where the patients had a HB of 9. So the conclusion is that, yes, fluid, you want to resuscitate the patient using blood, but it's not a fundamental aspect towards the management of this patient. Yeah.
Yeah, I think this is a very common question that I've seen not only in high resource settings, but also in resource constrained settings. And I think it's really, really important for us to recognize that giving blood and blood products does come with a lot of risks. So you can have infectious risks, you can have transfusion reactions, you can have circulatory overload. And so there's a lot of risk to giving blood and blood products. Additionally, I know in resource constrained settings, I have also worked in resource constrained settings, that blood and blood products are not always available. They have to be donated. So it's really also a struggle to keep our blood banks full of product and use them in a timely fashion. So in general, if the hemoglobin is 7 or above, we do not transfuse. This is in the setting of somebody who is anemic for some other reasons. Now, I know that Dr. Benjamil can tell us a lot about massive transfusion protocols and hemorrhagic shock. So if a patient is actively bleeding, then we would reconsider that advice. But if the patient is not actively bleeding, we typically do not transfuse unless the hemoglobin goes below 7. Dr. Benjamil, do you have any other thoughts about transfusion and its use in the management of fluid resuscitation for septic shock?
Yeah, you're absolutely right. And, this is where, clinical context comes into play. If clearly someone is in hemorrhagic shock and you're resuscitating, as we discussed in previous lectures, even in that case, you don't necessarily resuscitate with fluids to a certain hemoglobin level. And then in septic shock, certainly you're not as well. For the reason that you described, transfusion reactions, also risk of fluid overload by just targeting a hemoglobin number, which again is just a concentration which can be thrown off by the different fluid shifts in a patient with sepsis. So the other indicators that we've also discussed previously in terms of accurate resuscitation are far better, and transfusing with products to a certain hemoglobin has definitely been shown to not be effective. And even if you're not in a resource constrained setting, blood products are a valuable resource. So many reasons not to use blood products for resuscitation in septic shock.
Great, thank you so much. Any other thoughts from the panelists?
I think those are great points. And even in the emergency department, when someone is actively bleeding and we do have to transfuse, we will actively monitor that bleeding. And if it stops, we stop kind of transfusing them too, because we don't want to overshoot it. So.
Right. Okay, wonderful. So it sounds like we're all in agreement. Rachel, does that sound about similar to your practice in Kenya? Or do you think that people transfuse more often than that?
No, because just as you said, blood products are not easily available. So for the critical care patients, our protocol in majority of the facilities is when the HB is below 7. Well, yes, there's the issue of lack of the product, but there's also the issue of what outcome and what else are you trying to manage in that patient.
Right. Yeah. Right. Okay. Wonderful. Okay, so this slide is very busy, but I think you should just listen to the panelists instead of reading the slide. I do have a QR code there for postpartum hemorrhage, which I think is really a helpful resource to use. But we had a series of questions, and a lot of these are addressing resource constraints, so recommendations for therapies in certain situations versus the resources that are available to you in your practice. So I'm going to ask the panelists, how do you effectively manage shock in a low resource setting where time, labs, resources, and staff are not abundant. So some of the resource constraints I would say for managing shock include things like getting your arterial blood gases back. So maybe you don't have access to arterial blood gases. Maybe you don't have arterial lines or central lines. Maybe you don't have blood products. So maybe Dr. Kimani, what are your thoughts around managing shock? And when I say shock, that could be septic shock, cardiogenic shock, obstructive shock, hypovolemic shock. What are some thoughts that you have around managing resource constraints in the management of shock?
In our setting, it becomes, of course, there are challenges depending on now what type of shock that you're trying to manage. But we actually do have majority of the things that we require to manage the patients. We have the crystalloids, you have the colloids. For colloids, what's mostly available is Voluven, and I don't know if that's what you guys have. We have Voluven and gelofuscin. But for the crystalloids, we have Ringer's lactate and normal saline, which we tend to use mostly, especially for patients who have the hypovolemic shock, and when you're trying to do the fluid resuscitation. So it's not a challenge getting the fluids. So it's just a matter of identifying which shock that you have. And also you want to identify, is the patient having any renal insufficiencies? Is there any other organ dysfunction? So that it will guide you on the amount of fluid that you want to give the patient. Because if the patient has renal insufficiency, then you don't also want to have fluid overload. Yeah.
Yeah, I think you bring up some really interesting points. In regards to fluid resuscitation, Dr. Komisky, what type of balanced crystalloid fluid do you use most commonly when you're resuscitating somebody in shock?
I typically will lean towards lactated Ringers as being something that's readily available, because I find that it's the closest to physiologic state compared to normal saline, unless they have an underlying condition that would require maybe a little bit more of a sodium kind of boost. If they're hyponatremic, then potentially I'll lean more towards that. Or if they have a TBI or some isolated head injury, I will lean towards that as well. But lactated Ringers tends to be my first choice most times.
Danielle, do you know any negative effects of giving copious amounts of normal saline? What are some of the things in septic shock or shock in general that can happen if you give too much saline?
So you're going to give a salt load. You're also going to have a lot of chloride. So you could get some more kidney damage and like metabolic acidosis from the chloride that is within the normal saline.
Actually, yeah, that's absolutely right. So not only do you get a hyperchloremic acidosis, so thank you to Charles Lawrence, who gave that answer in the chat box. So giving copious amounts of saline can actually worsen the acidosis because the chloride ion has what's called a strong ion effect. And so you can actually worsen a metabolic acidosis. Additionally, the most recent guidelines, sepsis and septic shock guidelines, say to use a balanced salt solution, not normal saline. So if you have Ringer's lactate, lactated Ringers, some other balanced salt solutions are Plasma-Lyte or Normasol. If you have access to Ringer's lactate, I would use that instead of your normal saline. There's also been an association of increased renal dysfunction when we use saline as a resuscitative fluid. So this is a very common question, and I would say use your Ringer's lactate or lactated Ringers over normal saline. If you don't have Ringer's lactate, you don't have Normasol, you don't have Plasma-Lyte, then by all means you can use sodium chloride. But just be cognizant that you may have an additional acid load as well as a higher chance of renal dysfunction related to that resuscitative fluid. Renal dysfunction is a very common question. I just want everyone to realize that our next session next month is on renal dysfunction in the intensive care unit or in the critically ill patient. So we will certainly talk more about that. Many patients, because we have what's called a pre-renal hypovolemia, will go into some sort of renal dysfunction during because of shock. So we will talk a lot more about the different types of renal dysfunction in critical care. I think in general, when we talk about labs, and Dr. Kimani and Eddie, I welcome your input here. But when you don't have timely labs, sometimes you send off your labs and they don't come back for a day or two. And that means that the data is no longer actually valid or accurate. And so really you have to depend a lot on your clinical exam. When you have someone in shock, you know that they probably are hypoperfusing their cells. You know that they're probably going to be generating lactate because of anabolic metabolism. So when you have a patient who's in acidosis, you really want to follow your clinical exam to determine if you have resuscitated them adequately or not. So you can look at skin turgor, you can look at mucous membranes. The most recent guidelines recommend looking at capillary refill. Urine output is a good way to determine if the patient is fluid resuscitated. However, remember that people do have renal dysfunction, so you can get oliguria or anuria if you start to have renal dysfunction. Passive leg raise is a very inexpensive, non-invasive way to determine if your patient is responsive to fluids. One other thought that I have is when I know my patient is most likely acidotic, if they are on a mechanical ventilator, I will increase their respiratory rate to cause a compensatory alkalosis. So if I know that my patient is acidotic and they're on a mechanical ventilator, I will tend to set their respiratory rate a bit higher. Any other thoughts from the Kenyan panelists?
No, no, I think that's clear. That's what we actually also usually look at. We want to look at the patient now, depending on the patient's labs, it's not labs, the patient's clinical diagnosis is when you now decide what to do.
Yeah. Okay.
I just add one thing that in a very critically ill patient, if you are kind of overwhelmed with resources or their veins are hard to find, just an interosseous line can kind of get you started with the fluid resuscitation. If in that setting where you're lacking the time or just a difficult stick, we don't try to use it very often, but sometimes it's clutch.
Yeah, I've actually been in that situation. That's an excellent point. Okay, so we talked a little bit about blood cultures and antibiotic choices already. Do you start antibiotics if you don't have culture data? Yes. If the patient is in septic shock, that is a life-saving intervention. So you would start your antibiotics. You would start with broad spectrum antibiotics. How do you assess hypovolemic shock? We kind of just talked about that. You use your clinical exam, you use your capillary refill, passive leg raise. So ideally using a dynamic measurement of fluid responsiveness. If there's no availability of IV fluids, can we prepare oral rehydration salts instead? I would say absolutely yes. Assuming your patient's neurologic exam does not put them at risk for aspiration, oral rehydration is definitely appropriate, especially in children. So if your child is a bit listless, but they can still protect their airway, then oral rehydration is definitely indicated, and that's also for the adult. And then just to remember Dr. Walker's most recent point, if you don't have an IV or you can't get an IV, but you do have fluids, you can start an intraosseous line. How would you manage hypovolemic shock in the absence of blood products? So this person is losing mothers in low and middle income countries due to postpartum hemorrhage. I think that this emotive resources is very helpful. There's a lot of resources out there, and we will put those in the slides and on the Learning Resource Center about postpartum hemorrhage. I think it's also important to recognize we have another webinar dealing just with postpartum hemorrhage and obstetric patients, critically ill obstetric patients. So we will talk more about this. In general, you want to have blood products if possible, but the first thing is to stop the etiology of the bleeding. And so you need to determine, is this a laceration that needs to be sutured by the obs and gynae professionals, or is this uterine atony? If it's uterine atony, then uterine massage is indicated as one of the first line interventions to help that the uterus contract back down. So you can do uterine massage to help with that. You can use intravenous fluids if you don't have blood, but at some point you're going to need to use blood if they become profoundly anemic. Can you start colloids? We will use albumin on occasion in these patients. We typically do not use the other colloids such as hetastarch because they have been associated with renal dysfunction as well as some coagulopathy. So that might actually make things a bit worse. How about this question? How do you manage hypovolemic shock at the primary care facility? Does anybody want to answer this question? Some of your thoughts?
My thoughts would be with the oral rehydrating solution, if possible, assuming that there aren't fluids or many resources at this primary care facility.
Yeah, absolutely. So oral rehydration. I think also recognition when someone is critically ill, and if possible, start to arrange very early triage. So try to escalate care if possible. Sometimes that's not possible and you do the best you can, but oral rehydration if you don't have intravenous fluids. Dr. Benjamin, you had a comment?
Oh, no, I just saw the next slide is up.
Great. All right.
Yeah, so as Dr. Crawford mentioned, we're going to have sessions specifically dedicated to maternal hemorrhage. But in the meantime, these are some other excellent resources that you can see the QR code for that will give some guidelines on pediatric and obstetric anesthesia. Very useful for formulas and management of common scenarios. There's also the anesthesia tutorial of the week where you can search by topic, select the language you prefer, and there's a lot of great evidence-based high-yield tutorials on many topics. So some additional really useful resources as well.
Yeah, thank you. I'll just make one comment about the Pediatric and Obstetric Anesthesia Handbook. So the WFSA stands for the World Federation of Societies of Anesthesiologists. So every country that has an anesthesiologist society, this is the umbrella that brings all of those societies across the globe together as the WFSA. And within this pediatric and obstetric anesthesia handbook, there are really great information. There's really great information on types of medications to use, the dosages of the medications to use in pediatric patients or obstetric patients, what size endotracheal tube, really how much to fluid resuscitate, how much to transfuse. So a lot of these questions that are very common are addressed in this handbook. So it is available for download, and it's incredibly useful. So I definitely encourage you to do that for your peds and OB patients.
Great. And another really useful resource, the different types of ventilators. I think this really came to light during the pandemic when all of a sudden there's an influx of different ventilators, often new ones. And even here in the United States, different hospitals within the same city can have different ventilators or different modes. So this is a wonderful resource. You can download an app and then scroll through and select different types of ventilators to help familiarize yourself with their obviously all the principles remain the same, but the buttons are different, the interfaces are different, and you don't want to be figuring that out when when a patient's sick. So this is a really useful resource as well.
Absolutely. Yeah. I don't know how many times I've walked into an ICU or an emergency room with a ventilator I've never seen before. So most of them are very similar, but this definitely helps you. You can just pull up, okay, what type of ventilator is this and where do I find the right buttons? So that's a really great resource. Definitely.
Speaking of great resources for ventilators, this is another one. It's the Respiratory Care Pocket Reference. It has everything from non-invasive options to ventilatory modes to changing settings, looking at patient compliance, it's great. There's a lot of content here, which is worth looking at and having.
Yeah, this is such a good resource. This came out during the pandemic, and when we were all trying to manage hypoxemia and decide anywhere from, like, do we use nasal prongs or an oxygen mask or a non-rebreather mask? How do we set up the different types of ventilators? What types of parameters should we be looking at when our patient develops ARDS? Should we use pressure? Should we use volume? It's just such a really, really good pocket guide. So you can really use it at the bedside to help you make changes when your patient is struggling on the ventilator. It's just, I cannot emphasize enough how good of a resource that is. What about ventilator-associated pneumonia? How do we prevent VAP or ventilator-associated pneumonia in our ICU patients?
Look again, how do you prevent ventilator-associated pneumonia in ICU? The first thing, if we can avoid intubation, that is the first way of preventing ventilator-associated pneumonia. And therefore, we use high flow, or we use high flow for the most part. As long as the patient is protecting their airway, we will delay intubation as much as possible. Provide enteral instead of parenteral nutrition. So most of these patients, after intubation, immediately after intubation, they will insert NG tube or nasogastral or orogastric feeding tube. Most likely we want this to be post-pyloric to prevent that reflex, and therefore that is one of the ways that we use. Then minimize sedation. In most ICU settings, we do have what we call extubation trial, or SBT, which normally is done in the early morning, maybe anytime between 5 and 8 a.m. Minimize sedation, see how the patient is responding without sedation to the ventilator. Are they hemodynamically stable? And if they're hemodynamically stable, we can follow up with the arterial blood gases, venous blood gases, and just looking at the patient's hemodynamics if they're stable. If they're passing that, and they're able to pass the Karflik test and all that, and there's nothing else obstructing them from being extubated, then early extubation is preferred. Avoid breaking the socket. This is a lot of time is associated with pneumonia. So usually during transport, where they have to switch vents, if it's unavoidable, yes, it is. But if you don't have to do it, don't break the circuit. And only break it unless it is visibly soiled, is malfunctioning, or per recommendation of the manufacturer. Maintain and improve physical conditioning through active and passive exercises. In the where we have high resources, like here at Stanford, we have the PT session, OT session that is done, and then we have scheduled time where we want the patient to, get out of bed or sit in the chair and all that. Provide good oral care. That is very, very important. In most settings, is every 4 hours, good oral care. It's done, including the brushing their teeth, and if the patient can help with, coughing, or they'll do some other pulmonary toileting stuff to help. Set the head of the patient more than 30 degrees. That is typical for all our ventilated patients, unless there's something, going on other than just the pulmonary that can prevent us from doing that. We will maintain 30 degrees and 45. We've seen most of these patients, if they cannot be liberated from the vent, usually after 7 to 10 days, there's that introduction of trach or tracheostomy. And this seems to help and reduce that pneumonia. And also, once they're trached, the sedation, they can most of them can even be able to be on the vent, trached with very minimal sedation. Using endotracheal tube with subglottic secretion, we are seeing more and more of these available ET tube with that, and they've helped a lot, especially in our settings here. I already mentioned the post-pyloric, which we insert a feeding tube and we do an X-ray to make sure it's post-pyloric, and we use that to give nutrition to our patient. Oral digestive decontamination of low antibiotic use and liberating patient from antibiotics that they do not need do help with that as well. This is a guideline, and as we know, it's a busy slide, but there are other ways that are done in other settings. And if any panelists have more ideas, please share. Thank you.
Thank you, Eddie. Yeah, this is a busy slide, but there are many other resources available online for what's called a VAP, or ventilator-associated pneumonia bundle of care. And so really this bundle of care is used together in order to decrease the risk of VAP. Eddie, you do this all day, every day. Which of these interventions would you consider to be the easiest, and which would be the most difficult in your practice?
The easiest one is the oral care and sitting the patient up at 30 degrees. It's just it's like a second, once you walk in a room and patient laying flat, bring the bed up if there's no anything preventing you from doing it, and you do the oral care with your assessments. Most ICU patients, a fully thorough assessment is done every 4 hours unless there's a neuro issue going on. So every 4 hours, as you assess everything, you do those oral care. The most challenging one might usually be the keeping the patient active and awake, or doing liberation from sedation, because we get a challenge of where patient become really agitated sometimes, and these things are done. Our shift begins at 7. So between 7 and 8, some of the providers are just trying to get familiar with the patient. So there's that. They're not sure, should we liberate or should we not liberate? And in that time in the morning, you can run into a patient, get off the restraints and self-extubate, and it can come into a whole other thing to deal with. So usually that is the most challenging, especially if it's your first time experiencing that patient in the morning.
Absolutely. I think in general for ICU patients, the sedation management and ventilator weaning becomes a big challenge. I have seen, however, patients who are intubated for some other reason, whether it's neurologic or acidosis, and then they develop ventilator-associated pneumonia, and then they develop septic shock, and then they develop ARDS, and then that's how they die in the intensive care unit. So I can't stress enough that good bundled care for ventilator-associated pneumonia is of utmost importance, as is judicious sedation management and trying to get the patient off the ventilator as soon as possible. One of the things you mentioned, two of the things that you mentioned that I often think about together in my mind is head of bed. So we say 30 to 45 degrees. And then you mentioned that if the patient has a feeding tube, to put it post-pyloric. It's not always possible to get the feeding tube post-pyloric. If you can, that's ideal, but especially in places where we're putting it in blind and we don't necessarily have the luxury of getting an abdominal x-ray every time, it may not be possible to get it post-pyloric. You can put the feeding tube in the stomach instead of post-pyloric, but if the patient has any sort of gastroparesis or reflux, that will increase their risk of aspiration and pneumonia. So in those patients, I would actually keep the head of bed a bit higher. So if you can't get your feeding tube post-pyloric, I would tend to put the head of bed a little bit higher. What do you think about that, Mr. Owino?
I agree with you 100%. Yeah, there are settings where we don't have the luxury of X-ray, so keeping them 45 and above is ideal in those situations.
Yeah. Someone in the chat makes a great point that when you're suctioning the oropharynx, you might want to use a different tube when you're suctioning the endotracheal tube, because otherwise you're just introducing all of the bacteria and secretions from the mouth into the airways, which can increase your risk of ventilator-associated pneumonia. That's an excellent point. Thank you, Michael. Okay, wonderful. That is a lot. So thank you all so much. I especially want to thank our panelists. You've done an amazing job, and we always love to hear your perspectives, especially because you work in different settings and have different training and education backgrounds. So really, really grateful to all of you. We had multiple people ask in the chat, where can I find this? Where can I find that? I'm going to reassure you that right after this session, I will certainly upload every single one of these slides to the Learning Resource Center. I'm going to put that link once again in the chat right now. But everything can be found on the LRC. You do have to create your own account, but it's free. It's open access. You can share it with everybody in your institution or anybody that you want to share that. You can also scan this QR code. So for those of you who are not as familiar with QR codes, you can open the camera on your phone and shine the camera at the QR code, and it will give you a link to the website, and then you can just click that link and go directly to the website. So just in case. Please join us next month, May 21st. We're talking about renal disease in the ICU patient. I'd like to change that to the critically ill patient. But we're going to talk about kidneys and renal dysfunction in the critically ill patient next month. So please find all the slides there, and I'll have them up within the hour, I promise you. Additionally, I mentioned at the beginning of the session, but if you would like to get CME credit from Stanford University, you will get an email. If you attended this session, you will receive an email notification within 5 business days. It won't happen immediately, but you will get an email within 5 business days. It gives you a link to fill out an evaluation. If you fill out that evaluation, you will get CME or CPD credits from Stanford. Again, we want to thank the Department of Anesthesiology, Perioperative, and Pain Medication for sponsoring that CME. And with that, we are finishing right on time. Again, thank you all so, so much. We really love seeing you on these sessions. We're really, really happy to bring all of you together and to have such amazing panelists. So thank you so much to everyone. Thank you. See you next month.
Thank you. Thank you, everyone. Bye.
Bye.
Thank you. Bye.
Thank you. See you next month.
Bye. Glad to see you. Thank you so much.
Thank you.
Bye-bye. Thank you.
Thank you for your nice presentation, and it's more practical.
Oh, good.
One more
excited.
thing.
It was great.
Thanks.
Good.
Hello.
Thank you.
Thank you very much. Bye-bye.
Our pleasure. We're so happy.
Thank you very much.
Bye. Bye, Steve. Bye, Kevin.
Thank you.
Bye. Thank you. Bye.
Bye. See you next time.
Thank you for the nice
Bye.
presentation.
Bye.